That I was delighted to hear that a second CDG World Conference was coming and that Vanessa and her team have really managed to put everything together and to get so many people together. It's for us professionals so important to meet families and patients, some that we know and other ones that we have not seen, and we learn a lot by just talking to each other, which is fantastic. When I was asked to speak, I thought it was a privilege to be here. At the same time, I thought, like, why am I talking about the management of gastrointestinal findings in CDG? So I'm not a gastroenterologist, but it is true that in the years of looking after patients as a pediatrician and metabolic physician with CDG, I have encountered a lot of gastrointestinal problems in my patients, and hence what I did was I sat down over the list of patients I've seen over the years, and I made a list of what have we seen as gastrointestinal problems in them. So as we have heard from Dr. Ormond already, we see a lot of feeding problems in CDG patients. We have quite some patients that have gastroesophageal reflux. We have a lot of patients with failure to thrive, particularly when they're very young. We see in more specific cases the protein-losing enteropathy, and we have liver disease and might see liver fibrosis or even cirrhosis in CDG patients. So when I did my list of this and a list of the patients that I have seen any symptoms, I have to say that about 70% of all the CDG patients that I had under review had some symptoms of this list. So just remind ourselves, any CDG child is as well a child, and gastrointestinal problems in any children, even without any other diagnosis, is actually fairly common. So feeding problems in CDG might be CDG related, or they might not be CDG related. So let's talk about feeding problems, first of all, the general things. So what are feeding problems, or why do they occur? First of all, it could be that the baby's just not taking enough food in, and it's just falling asleep whilst you're feeding. Or it might be an insufficient sucking, and it just gets really tired out whilst you're feeding. It might be that the baby has discomfort when feeding and has a lot of gas or stomach pain, and that's probably because they are just swallowing a lot of air and the swallowing is not quite good coordinated. But it could be as well that they have lactose intolerance, something that in a normal pediatric population we would think about as well. It could be that the baby cries hours after the meals, and I'm sure that some of you have encountered this problem. And you will think about, has the baby colics? So what we need to do is we need to find out what's the reason for the baby's feeding difficulties, and we can probably try different, or we should try different things. For the first, the baby falls asleep during feedings. You will try to manipulate by using different positions. You might have to exchange the bottle. It might be important that actually the clinician reviews the child when feeding, because we might pick up other clinical signs and symptoms that explains for us why the baby's feeding just for a short period and then stops feeding. One can obviously as well consider to switch formulas, and for colleagues you will be very aware that you will probably try to rock the baby, use a cradle, or have baby massages. So another feeding problem that we see is the baby feeds large amounts of vomit. And this is a picture of a patient that's from Google Images, thanks to Google. And it just, you can see that this baby has a very forceful vomit. And that would make us think, has the baby pyloric stenosis? The baby seems, the other feeding problem could be that the baby has a slow weight gain. So we would think then about, is this baby actually absorbing everything that we put in? It's then, even if it takes in all the nutrition that we're giving by the feeds, is it actually able to use those feeds, to digest the feeds? And it could be that you have a young infant that seems to have little interest in food in general. So that again is quite an important finding, because it might already be a very early sign for a baby that is going to encounter in the future developmental problems. So what do we do with those different questions? Now, if we have the impression it could be a pyloric stenosis with this forceful vomiting, we have to do an X-ray and see if there are abnormalities in the anatomy of the esophagus and stomach. then in the case that we have a slow weight gain, we will ask for different investigations to see what the blood results, the urine results, and as sometimes we need as well to test the stool to get a better idea where the problem sits. And then if we have the impression the poor feeding could be because of a developmental problem, it's crucial for the clinician to have an overall aspect of the child, to really have a thorough examination to see if there are any clinical signs and symptoms that might pinpoint to the fact it's actually a developmental problem. And we often include then our speech and language therapists, who are ever so good, to see if there is a discoordinated swallowing, how the baby is actually, or the young infant is coping with anything that goes towards the mouth. So how do we manage those patients? Well, we try to adjust the feeding routines, and it's amazing when you talk to parents what they have already had in place and what kind of things they have tried out. We can consider to increase the calorie intake because it might be that that baby needs just more calories to get a better weight gain. One might consider to exchange the milks or the food that the young infant has. And it might as well be, for example, when we have the impression it could be lactose intolerance, that we are going to try an exclusion diet for the children to see if that helps with the weight gain. So just to talk about gastroesophageal reflux, which is something, again, that we see in a common pediatric population quite often, but can affect as well our CDG children, and they have a higher incidence of reflux. So you have this typical unhappy crying baby that's spitting up after feeds particularly, and or you just simply hear after or during a feed this funny noises coming from the baby, the gurgling, and the baby's crying, whimpering. So the gastroesophageal reflux is a problem in the sphincter, the part of the esophagus to the stomach, that should actually prevent that fluid from the stomach is getting back into the esophagus, is not working properly. So there is a gap, and all the content of the stomach can go back in the esophagus, and that hurts. So how do we manage those patients? Now, if there is even the hint, it might be a reflux, parents will have already started to have their babies upright during and after feedings, 20 to 30 minutes after feedings. We usually then give the recommendations to have smaller and more frequent feedings, and sometimes we give the advice to have thickened feeds. And it's an obvious one. If you have any baby on breastfeeds, the mum will avoid anything that can potentially lead to a reflux problem in the baby. And the rule of thumb is no go for anything that's acidic, fatty, or gassy. But sometimes even those kind of smaller intervention do not make a difference, and we have to consider to give some medication. The medication we would think of is Gaviscon, which mixes with the gastric content and then thickens them, or we might use ranitidine, which actually reduces the stomach acid, and that then helps secondary to for the inflammation to settle down and the esophagus lesions to heal. But sometimes, because the reflux is too bad, we need to think about a surgical intervention, so to support the closing of the area between the esophagus and the stomach. And that's what probably some of you have had done for their children. It's a Nissen's fundoplication, where the surgical team takes the own stomach and esophagus area and wraps it around the esophagus so that you have a closure there and the reflux cannot happen anymore. Now, if we look at the issue of failure to thrive, then just as a definition, this is the inappropriate weight gain for any child. And I've now listed these reasons why a child, and a CDG child obviously, can have a failure to thrive. It might be that we simply do not get enough nutrition into the children, because as well the problems that I've just described. It might be that you get enough nutrition into the child, but unfortunately there is a difficulty for the body to absorb all these goodies that are sitting in the stomach and in the gut system, or it has increased losses, so it just passes through and doesn't get really taken up in the blood and then being used in the body. It could well be as well that the child has increased requirements, and we are just not able to get enough calories into in reflection of increased requirements. And sometimes, and this has been partly as well covered by Dr. Mohammed, we have ineffective utilization because the body doesn't know what to do with the food and how to do it. Now, when I do my clinical practice, I see sometimes the parent's face changing when I do open the clinical notes and I start to look at the centiles of the child. I think it's something that other clinicians see as well. I think that's always quite a stressful moment for any parent that has a child with gastrointestinal problems of any sort. Why do we always want to look at the centiles in a child that comes to our outpatient? This is the best way of looking if we have a failure to thrive. If we have a problem, what's the dynamic of the problem? So in this case, for example, you see this is the weight, this is the height of the child. You see that the weight was plotting along this lowest centile, but it was plotting along here. And then you appreciate that over time, this is over time, the little dots of the weight of this patient fall away from this lowest centile. So that was an indication that we had a failure to thrive here, that we were not able to have this child to follow these centiles. And then we have to consider all these different reasons and have to find out why that possibly is. And because this child has been thriving before, you really think about something that you must be able to change, because we were following the centiles previously. So let's go through the list of the different reasons for inappropriate weight gain, such as the inadequate nutrition intake. So it could be, again, the feeding difficulties. It could be the inadequate appetite of the child. And it could be as well that the baby is simply not able to take enough volume. So the other point, the inadequate nutrition absorption or increased losses. It might be that the child has what we call malabsorption, which is the inappropriate uptake of the nutrition from the gut, a general gut disease, and even a structurally abnormal gut, and we have to look into that. The increased requirements or ineffective utilization can be, for example, heart disease, and we've just heard from the previous speaker that there is heart involvement as well in some of the CDG, potentially as well in the PMM CDGs, the hormonal imbalances, and ineffective metabolism. So, looking at the management of the failure to thrive, the most important is that we are carefully exploring what the reason is for it, first of all. So there needs to be a thorough review by the clinical team. We often have then the dietitian, and we often have the speech and language therapists that help us. And we sometimes have to do investigations, blood, urine, stool, and others. And as a reflection of the inappropriate weight gain, we will then try to increase the daily calorie intake. We try sometimes to increase the density of calories in feeds, because if you increase volume in these children, they might vomit even more, and it's even a counterproductive thing. So you rather have to stick to the volumes that the patient is tolerating and increase the calories in the feeds. Sometimes spreading out feeds is really helpful, and I'm afraid quite often we end up needing to advise continuous or bolus feeds, but bolus feeds being aided by either a tube, or if it is a long-term solution we have to find, then it is a gastrostomy, and this child, for example, has a button. Now, in the case that we have a child that needs a tube, gastrointestinal tube feeding, or a button, we always encourage the family to keep on trying to feed orally. So if the child is safe to swallow, if we have don't stop from this speech and language therapist to say, no, this child isn't safe to have something orally. If that has been excluded, the child is safe to have anything, even you have a tube-fed child, then we should continue to stimulate the children around their mouth, because the mouth is not only important for swallowing, it's as well important later for speech development. And it's an area that needs to be worked on, even if you have a child with feeding difficulties. Now, coming to the list of the gastrointestinal problems, which are probably now more specific for CDG, we already heard about protein-losing enteropathy, which is really something very rare in the general pediatric population. So it's the protein loss, as we have heard, in the gut, and the clinical signs and symptoms can be really severe. It can be very, very bad diarrhea. It can be very bad abdominal pain. And we can even see profound bleeding of those children, gastrointestinal bleeding. And we see that in different CDG types. In the very beginning, we thought this was a very classical manifestation only in the PMI CDGs or CDG type 1b. But that's definitely not true. We have seen it in PMMs. We have seen it in ALK6, ALK8 patients, and occasionally even in other CDGs. So this is a difficult diagnosis to treat, and at that point, I would always have the gastroenterologist to help me to manage such a patient. And there is a management which will be individualized for the case. So we sometimes have to use diuretics. We sometimes will manipulate the diet and will go probably for a low-fat diet. We might have to consider corticosteroids. And then specifically in CDG 1b patients previously, heparin has been tried and it was felt to be a helpful agent in the protein-losing enteropathy in those cases. Another thing that's more specific for CDG are the increased liver enzymes. And I'm sure that a part of the families here have been sitting with their clinicians over ALTs and ASTs and gamma GTs, which gamma GTs probably less, but they've definitely ALTs and ASTs, which have been high and then as well low whenever the child was well. And that's something we see in PMM particularly. So in unwell episodes where you have a stress as well on the liver, then we can see ALT, AST going up. But equally, we do usually see that those liver enzymes do settle over the time and during well periods can be absolutely normal. So the main thing is to monitor for the clinicians to see what is our dynamic and to see that they are settling again. And if not, we need to do further investigation. Because we know as well that children with congenital disorders of glycosylation can develop liver fibrosis or liver cirrhosis. Fibrosis is a scarring process in the liver. So liver tissue is replaced by connective tissue, if you want, and it's usually initially reversible. But once it comes to the step of cirrhosis, it isn't. And again, we will carefully, in any CDG patients, evaluate the liver function test in blood, but we will have as well the need for abdominal ultrasound if we have the impression liver fibrosis could be going on. And sometimes we need liver biopsies to distinguish between fibrosis and cirrhosis to see how far we are in liver changes. Now, I made this little table just to remind us that there are different gastrointestinal findings in CDG, which are, and I have just listed here 4 CDGs out of the over 80s that we know, just to say that we have a scattered picture. A lot of them have gastrointestinal problems, but a 2+ means it is present. A 3+ means it is present in a lot of patients. A 4+ is present in even more patients. And you see the range as well. So you do not have to have severe feeding problems in PMM, but it is quite frequently seen, and it can be actually quite severe. Failure to thrive, we quite often see in CDG, PMM CDG, for example, but I have seen children that are orally fed and you have no problems with, for them to put on weight, which is the smaller group in PMM CDGs. Now, I want to stress that a congenital disorder of glycosylation patient does not necessarily need to be a tiny, weeny failure to thrive patient. We have as well patients that actually come with overly good weight, obesity, and that's particularly, for example, seen in the MAN1B1 patients, which is one of the clinical features, actually, that helps the clinicians to consider this differential diagnosis. Protein-losing enteropathy I've already covered. We primarily see that in the 1Bs, but we can see that as well in other diseases like the ALK CDG. And liver abnormalities we have seen in many of the transaminitis, if you want, elevation of ALT, AST, we have seen in many different PMM and other CDG subtypes. Now, my main thing is if a child with any sort of CDG and any sort of gastrointestinal problem is coming to our clinic, we make sure that we include all the important people that need to help us to actually get the child to thrive or overcome any weight issues or feeding issues. And we usually have the local pediatrician being involved, then they come to see us as specialists. We involve our dietitians, and possibly even a feeding clinic appointment is set up. We need the diagnostic parts like biochemistry and radiologists to be helping us. We ask the surgeon for the ones that need Nissen fundoplication, for example. And the most important players are obviously our parents and families in the day-to-day management of those symptoms. So many thanks.